We'll slowly have a few more attendees. Let's wait for a few minutes and then let's start.
Going up and down.
Yeah, I saw that as well. It's like, are people going? They're like, no, don't want to attend this. Too quiet.
Yeah.
Shall we make a start, Tom?
Yeah, sure thing. Okay, well, welcome everybody to the OHBM Australia chapter webinar, Unraveling the Mysteries of Brain Change, comprehensive look at brain aging. Before we do begin, I'd like to do the acknowledgement of country. So we acknowledge the traditional custodians of the land on wherever you're meeting today. For me, the Turrbal and Yugara people. We pay respects to elders past, present, and emerging. I'd like to just hand over to my co-host, Sina.
Thanks, Tom. So welcome everyone to this OHBM webinar on Unraveling the Mysteries of Brain Changes, a comprehensive look at brain aging. So today we'll explore the fascinating realm of quantifying brain aging and its potential to predict future health outcomes. We've gathered a distinguished panel of experts who will share their insights and applications of brain aging models and approaches. Please also remember to prepare questions as we will engage in a shared Q&A session right at the end of all presentations. So get ready to gain valuable knowledge in brain aging and its applications for health and well-being.
Without further ado, so let's just introduce our first speaker, Professor Nicolas Cherbuin. So it's my great honor to introduce Nick, as he was my former master's supervisor many years ago. He's a renowned expert in the field of brain aging, serves as the director at the Center for Research on Aging, Health and Wellbeing, and the College of Health and Medicine at the Australian National University. He's the chief investigator of the Path Through Life study, a large longitudinal study surveying 75 individuals spanning the ages of 20 to 80 years, who've been followed up for the last 20 years. Professor Cherbuin's research focuses on understanding the factors that influence brain health and plasticity throughout our lifespan. So we're really eager to hear your insights today. So please join me in welcoming Nick. Thanks very much.
Thank you very much, Tom. Let me share my screen. Here we are. All right, well, thank you very much for this invitation to contribute to a discussion on brain aging, one of my favorite topics. And so, let me see if I can progress. Here we go. Just cutting to the chase, the main takeaway of my talk today is going to be about brain aging being a lifelong process, and that in order to better understand its component and its development, and to develop effective strategies to address it, we should really focus our attention and research much earlier in life than has until now been the case. And this is why I start with this beautiful photograph of a baby. So one important thing to think about when we talk about aging is why not just what happens, but how we think about it matters. And this is because depending on how we think about it, we can stigmatize people. We might present aging as something that excludes people or shows them in a poor light and depreciates them. Another aspect is depending on how we think about aging, we might think differently about whether we can prevent it or how we can prevent it. And lastly, depending on how we think about aging, it will influence when we think we can take action on aging. So these are important things to think about beforehand. But let's start this story at the beginning. I'm going to try and take you through an informal journey of my thinking about brain aging, how it has been unfolded through my career, because I think many people start in this way, and maybe by sharing this this bit of history, people might be able to sort of jump straight to the more important aspects, I think, that are relevant for brain aging. So many of us, including me, often start thinking about brain aging in old age, and particularly in relation to dementia. This makes sense because it's a huge problem. There are millions of people worldwide suffering from dementia, and this is due to increase dramatically in the next decades. It's also associated with a huge social and economic costs. Here we can see the cost of dementia annually compared to the value of Tesla and Facebook, and the costs are really astounding. And if dementia were a country, it would be the world's 18th largest in revenue. It's also important because the increase in dementia is going to affect more those countries that have low to middle income, and they also have those who are least able to deal with this problem. It also makes sense because it's much easier to detect, right? We can look at an MRI, we can look at these photos of postmortem tissue, and the problem is obvious. We can quantify it, we can detect it, and we can it's easy to characterize them. It's also an area where well-established technology such as MRI can be used in the clinic to confirm diagnosis. So it's very useful. And having talked about MRI and structural MRI, I just want to own straight away that this talk is going to be much about volumetrics based on MRI scans. And the question is, I can hear some of you already thinking, but Nick, this is 20th century technology and there's so much other cool stuff, fMRI and EEG and neurofilament light chain. Why focus on volumetrics in a talk like this? And while I completely agree with the notion that there are new methods that are very exciting, the problem we are facing in the context of aging is that we don't really have reliable metrics and norms to be able to understand aging and brain aging across the lifespan, whereas with volumetrics, there's a clear metric that we understand very well. The one problem with focusing on dementia to characterize brain aging is that while it can be useful to diagnose for diagnostic purposes in the clinic, there is relatively little that can be done to alter brain aging at this late clinical stage. And you will all have seen many headlines saying that this new treatment is going to be available soon, there is actually no cure for dementia, and even in recent times we've heard about some approved drugs. They actually I hear from clinicians that they often not appropriate to be used in the people who really need them because the side effects in these older populations are too high. And so we might think, well, then how about we look at brain aging one step earlier, which is, has been my thought. Then maybe we can detect brain changes that then we'll be able to identify individuals that are more at risk of accelerated brain aging and dementia. And we've done this in a number of ways. Here, I'm just showing sort of results from a systematic review, sort of looking at the volumetric differences between mild cognitive impairment and normal aging across the literature. And indeed, we find that there are consistent differences in MCI versus normal individuals. And then the next question might be, well, then can we use these differences, if they're consistent, to predict conversion to dementia and better understand what might lead to further changes. And we've looked at this using data from the ADNI study. And that's work from my PhD student, Hossein Tabai. And what we and others have found similar things using a number of predictors is that while in the population we can predict here it's a prediction of conversion from mild cognitive impairment to Alzheimer's disease over 5 years. And we can predict this conversion, but it's not clinically very useful. It works in the population, but as soon as we turn to the individual, what we found in this data set is that unless people had very small hippocampi below total amount between left and right of 5 milliliters, at which case MMSE didn't matter anymore, or other cognitive abilities didn't matter. There was a fairly sure conversion within 5 years, which then might be practically used in the clinic. Beyond that, it's not precise enough, and therefore clinically not useful. Many others have tried to use machine learning and cortical thickness and more complex measures with relatively similar results. It's possible to predict in the population conversion, but effectively applying this in the clinic and in the individual at the individual level is not really working. It's not exactly surprising. So if we think about the pathology, we often conceptualize dementia and Alzheimer's disease as relatively pure conditions, right? We know that Alzheimer's disease is characterized by neurofibrillary tangles and plaques, and we kind of idealize these things. But when we look at here on this figure, the type of presentation postmortem in people with dementia, we find that while there are some people who have relatively pure Alzheimer's disease or other pathologies, the vast majority, that's almost 60%, have mixed pathology, and therefore it's going to present in the brain in multiple ways. And this is only part of the problem. The same study looked at not just in pathology in dementia, but also in cognitively intact individuals living in the population. And as you can see, a substantial proportion, probably about 60%, have pathology in their brain that is consistent with having dementia. And other studies from other researchers have found similar things, that 20 to 40% of cognitively intact individuals have postmortem Alzheimer's pathology, and around 7% are in the advanced stage, Bragg stages, indicating a high tauopathy. And so conceptually, aging or having dementia, and some people view this as aging completely separate from dementia, or overlapping, or some people conceptualize it as just a continuum. It's tricky to sort of think of aging with these complexities, especially in old age. So next, our thinking and others as well has been, well, if this is not working so well and there isn't much we can do in older age, maybe we can better understand how aging affects the brain early in life and have an impact there. And so we conducted some systematic reviews to look as well at the change in hippocampal volume across age. It's a coarse measure, but it just meant that we could have sort of more precise estimates. And we can see on the right-hand side a systematic review from Bars and colleagues showing that hippocampal atrophy in dementia is about 4% per year. And we've seen before in the previous slide that in mild-cognitive impairment it's about 2%. In normal people, it's about 1-point-something% at ages 70 plus, under 1% between 55 and 70 years. But what was interesting is that below 55 years, the estimate was around 1/3% per year. And this was fairly consistent. So we didn't find an age gradient, but the systematic review was limited by the type of studies we could include and the age range and so on. And so it's not super precise. Others have done a much better job of addressing this question than we did in this previous systematic review. So Bethlehem and et al. Looked at 100 studies that included 125,000 people, including from the UK Biobank study, the ADNI study, and others, but in cognitively intact participants. And this is a summary slide, and it's quite a busy slide. So we've got age down here, and we can see that adulthood starts around here. And what I just particularly want to attract your attention to is that there are declines in brain structure in the gray subcortical and cortical gray matter, as well as in the white matter that peaks a bit later and then declines as well. But the point here is that the structural changes linked to aging start at least in the early 20s and probably somewhat before. This is from the same study, and I'll just attract your attention to the top of the figure, because I want to highlight the fact that there is a fair bit of variability in between males and females, but across both sexes. And this is when we see we saw the previous slide, we don't really, it seems all neat and clean and you know, we've got a clear trajectory. But even on this slide, it looks tidier than it really is. Tom talked about the longitudinal study we have here in Canberra of 7,500 people. And in this cohort, we looked at hippocampal change across 12 years in a middle age group, 44 to 56, and well, it's really 40 to 56, and 60 to 76. And we've modeled the changes in left, right, hippocampus in males and females here. But what I want to attract your attention to is that the type of trajectories we get is what we see in the background here. So we end up with very tidy trajectories, but the underlying data is actually very noisy. And also people so follow quite dramatically different trajectories, even if we account for noise. But what was particularly interesting in this study is that in the older age group, if we look at groups of people that for different trajectories using latent class analysis, we find that, yes, there are people who continue declining quite fast here in blue, but this is only about 30% of this sample. And they're representative, I should have said this sample is representative of the population. Whereas the other 70% is actually remarkably stable. So it's not the case that everyone declines at the same rate. And so the question it raises is, well, what is it that determines whether our brain ages and atrophies faster or slower? A lot of research has been conducted in relation to risk factors for neurodegeneration, particularly in relation to dementia, because again, it was a kind of a clear outcome. And I won't go through all these estimates, but you can see that all these systematic reviews have been done across large samples and have fairly big effect sizes. But the thing is, you know, it doesn't tell us when the effect of BMI or diabetes or depression might have an effect on the brain that then leads to a future development of dementia. So to address this question, we've again used a number of systematic reviews, but trying to use brain volume as an outcome so that we wouldn't have to use the data from studies that focus on dementia. This is partly because if the outcome is dementia, it's very rare that the exposure, having had depression or diabetes, is really measured in early adulthood or even mid-adulthood. And so the intention was here to get closer to get a better understanding of when these effects starts impacting the brain. And what I won't go into a great deal of detail, but what we find, for instance, in relation to depression, is that there is a 1 to 4% lower brain volume in people who have depression. But a key finding of this study was that there was no effect of age. The age range was between 20 and 80. And despite large sample sizes in meta-regression, we did not find an effect of age. This suggests that the effect the brain difference might already be there early in adulthood and certainly in mid-adulthood. And so I won't tell you about all of them, but we went through other known risk factors for brain aging. And similarly for type 2 diabetes, we found that having type 2 diabetes was associated with a similar 1 to 4% lower brain volume, depending on whether it's total brain volume or the hippocampus or other regions. And again, the age range was quite wide, 30 years to 80 years. And similarly, there was little effect of age, but where there was an effect, it's not that it increased with age, it actually decreased with age. Again, suggesting that some of these effects are really present well before middle age or certainly old age. And another one of these systematic reviews that we conducted was on hypertension and blood pressure. And similarly, the age range was a bit narrower here, 52 years to 81 years. But we found no effect of age either, sort of leading to the same message. But of course, there are limitations, as we've noted before, about using systematic reviews. The somewhat blunt instruments. We have to start somewhere, and it guides our thinking. But really having fine-grained data to better understand the variability is really what is needed. So we've also conducted some of these similar investigations using the UK Biobank. So here the focus is on sleep quality. We did this as well with diabetes and blood pressure and other things. But for variety, I thought I'd tell you about this one. And again, here in an age range between 40 years and 80 years, we've found a consistent effect of sleep quality measured in different ways. So if for every additional hour over 7 hours of sleep, it would be protective with less brain shrinkage, whereas below 6 hours and above 9 hours, there would be greater shrinkage. But again, we did not detect almost any effect of age. Again, suggesting that some of these exposures that may occur quite early in life have apparently a relatively similar effect earlier than later. And this brings us to questions around, well, so what are the type of mechanisms that are associated with these changes? Because we started with dementia, I thought I'd just talk a little about the possibility that the underlying pathology is already some of the hallmarks of Alzheimer's disease developing. We know that they start developing decades before. So maybe these are the types of things that underlie some of these effects. And while it's possible, we can see here data from a relatively old study from Brack and Brack, but that has been repackaged in this Brack and Tredici paper. And what it shows us is the presence of absence of neurofibrillary tangles in the first two rows and amyloid beta across severity stages from left to right. And the key point is that, for example, abnormal tau and neurofibrillary tangles can be detected from the 20s onwards. The more acute phases develop somewhat later, more in the 40s, 50s. And similarly, with amyloid beta, it's even a bit later. It's detectable in the 40s and or somewhat earlier, depending on the phases. but not necessarily very early. And so this brings us to the question of, so what is it that leads to the type of brain aging we're seeing if it's not these major mechanisms that lead to dramatic brain changes in old age? And so one, there are broadly four mechanisms that contribute to aging. One is that from conception, our biological tissue is continuously damaged by components of an internal or external environment, such as viruses, injuries, inflammation, oxidative stress, UV exposure, and so on. Fortunately, we've developed very effective mechanisms to repair this damage. And a third aspect of aging is that our body produces rubbish, as in misfolded proteins and other things like this that for instance lead to dementia in the case of the aggregation of amyloid beta. And the fourth mechanism is rubbish removal. Again, we've developed very effective ways of clearing the body of damage and unwanted products. But as with repair mechanisms, the rubbish removal mechanisms are not perfect. And so over time, we accumulate this damage that is progressively fixed, but incompletely. And so it accumulates and it starts clogging our system. And if we conceptualize aging in this way, it makes complete sense that its effects should be detectable relatively early in life. And this is, and of course, it impacts not just cells, but also tissues and the capacity to function. So if we look at the relationship between aging and a number of biological conditions or processes, we can see that the metabolic rate, for instance, decreases steadily from 20 to into old age, and presumably this is linked to a progressive damage and misrepair of mitochondria and the capacity of producing energy. As we unable to produce energy as efficiently, it's then no wonder that we tend to put on body weight. And here on the left-hand side, we can see different the change in obesity rates across different generations. And what is key here is that it's not just that it increases and that it seems to be linked to the type of biological mechanism we talked about, but it increases sooner and faster with newer generation. And this points to not just biological mechanisms, but these mechanisms interacting with other exposures, the fact that we might eat more or worse food than we might have before. And a similar point is made on the panel, the top panel on the right-hand side, where we can see that this effect is moderated by education, where there are low increases in obesity rates with age, with high education. And so we always have to be careful when considering biological mechanisms that might influence aging and brain aging, because they're going to be linked to other social, environmental exposures that will modulate their effects. I won't labor these points too much, but a similar thing can be seen with blood glucose, and there are also differences between males and females, and between diabetes rates with increasing age as well across different age group. All this has, unsurprisingly, also an effect on function. And here, if we think of brain function cognition, this is one of the first studies that has looked at that quite systematically to show that between the 20s and the 80s, the cognitive function tended to decline fairly linearly, again, consistent with these underlying processes, although I want to highlight as well that some of these processes or some of these cognitive domains are less affected, such as world knowledge and lexical knowledge. So to better understand how the type of underlying biological processes might interact with other factors, we looked in the Path Through Life study in a subsample of participants who have an MRI at the association between measures of oxidative stress and inflammation in their blood, and the likelihood of them having mild cognitive impairment, experiencing a change in mini-mental state examination, or a change in hippocampal volume. And to do this, we used a number of inflammatory factors, TNF-alpha, a number of interleukins, as well as a number of measures of oxidative stress. But instead of just trying to, all these facts, all these inflammatory processes and aspect of oxidative stress, it's not on and off, they interact with each other. So to better understand how a state of inflammation or of damage due to oxidative stress might impact brain aging and cognition, we used a principal component analysis to extract states of inflammation. And then we tested the association between these states and the outcome, having mild cognitive impairment, having a decreasing MMSE, or a change in hippocampal volume. And while I don't have the time to go in details into all these things, we found 4 broad states of inflammation based on the I think 13 inflammatory and oxidative stress measures and DNA damage. And what was interesting is that different aspects of inflammation were associated with overlapping but different outcomes. So some of the components were more predictive of developing mild cognitive impairment, and some were more predictive of a change in hippocampal volume. What it was particularly interesting is that we hypothesize, especially because the literature says, talks a lot about inflammation as a process that leads to brain aging and neurodegeneration. So we included oxidative stress and DNA damage, but we were more focused on inflammation. But what we found is that actually a greater part of the signal was around antioxidant activity and oxidative stress and DNA damage due to oxidative stress, which also makes sense because oxidative stress is something that happens from conception as a normal byproduct of living, of producing energy, and therefore it kind of makes sense, but it was still surprising. Another interesting aspect is that
sorry, Nicolas, to interrupt you. We just have to be mindful of the time. Would you mind wrapping it up if possible?
Sure.
Okay, thank you so much.
Yeah. So very briefly, we found that it related to lifestyle and health factors, and when we looked across not just this older cohort but a middle-aged cohort, we found much the same factors, and they also related to the presence of amyloid beta and tau in blood, presumably as a reflection of the levels in the brain. Hopefully through this quick and sort of fairly general talk, I've been able to communicate that we often start thinking about aging late in the process, and then it takes us years to start realizing that really what probably matters more is what happens earlier. And so this is what that's my main message. And in terms of where next, there are some unresolved questions. For instance, why do some people experience greater brain aging than others? Sure, some of the reasons might be linked to risk exposure, lifestyle choices and so on, but it's not only the case. Some people, as we know, have the worst lifestyle and live for longer. What are critical age windows for brain aging? Again, we've often it's thought about midlife and after, and I would argue that it's probably earlier, but we don't have enough data on this. What contributes most to brain aging? That's, again, we don't really know. We know about a lot of risk factors, but we don't know about which one is the key one. How can we prevent or delay brain aging? There are many interventions, physical activity, diet, but again, we don't know exactly when it's more optimal to start them, and which one is going to be more effective. What contributes to differential brain aging trajectories in men and women? There are differences. Some of them are also due to lifestyle factors, but it's likely that others are due to biological factors, and we don't really understand them very well. And can effective population interventions be developed to slow brain aging? Because ultimately, this is the key thing to impact people's life, is really develop evidence that decreases risk in the population. And sorry if I've been too long. Thank you for your attention.
Thanks so much, Nicolas, for your presentation. It was a lot of insightful findings and results, I'm sure. There are a lot of burning questions. I just want to remind everyone that they could post their questions in the Q&A section, and we will attend to the questions at the very end. With that, please allow me to introduce our next speaker, Associate Professor Vanessa Cropley from the University of Melbourne. She currently leads the Translational Neurobiology Group at the Melbourne Neuropsychiatry Centre. Professor Cropley's research focuses on investigating the intricate relationship between the brain, biology, and behavior in mental illnesses. Her work adopts a developmental and biopsychosocial framework to understand how typical and atypical brain development influences the onset of mental illnesses and is influenced by environmental, biological, and psychosocial factors. Without further ado, we invite Professor Cropley to take the floor and enlighten us with her insights on brain aging models and psychopathology.
Thank you so much, Sina. I'll just share my screen, just bear with me. Okay, I'm hoping you can see that. On the back of that was just such elegant work by Professor Cherbuin. That was amazing in terms of the program of research that you have actually undertaken. So I'm going to shift gears a little bit, and I'm going to really just focus on one study. So it's going to be a lot more simple than the previous really elegant program of research. And I'm going to shift gears to an earlier stage of development and how it might actually associate with psychopathology or subclinical symptoms of mental health in youth. So just as a bit of a background as to why we're focusing.
You're not sharing any slides.
Oh, goodness. Sorry.
Oh, that's all right.
I did that before, didn't I?
Yeah. Yeah, this is perfect.
Right. Thank you for the interruption early on. So then just as an introduction to why we're focusing on this earlier stage of development and also in terms of psychopathology. So it's relatively well known that many mental health disorders first emerge in youth, particularly during adolescence and young adulthood. So this is a recent epidemiological meta-analysis that has characterized the age of onset of mental health disorders around the world. So this study has shown that the global onset of a first mental health disorder occurs before the age of 14 in 1/3 of individuals and occurs before the age of 18 in almost half of individuals. And so this figure here to the left shows that the median peak age of onset is 14.5 years for any mental health disorder. So this really does illustrate that many mental health disorders begin largely earlier on in life. And as illustrated to the figure or schematic to the right, mental health disorders also contribute to significant total health burden around the world, including in Australia. And this is presumably because of the early age of onset that then contributes to this lifelong functional disability. So this is just an extension of the previous epidemiological study that illustrates the peak age of onset across a range of neurodevelopmental and psychiatric disorders. And so this does vary across the type of disorders. So the age of onset is in early childhood for neurodevelopmental and anxiety disorders. It's in adolescence for obsessive compulsive or eating disorders, and in late adolescence to early adulthood for substance use, mood, and also psychotic disorders. So as we've all, probably aware, there's also substantial changes that occur during adolescence in both structure, function, and organisation of the brain. And this has been elegantly described in the previous talk. But we know that these trajectories in brain development vary widely across regions, across particular brain metrics, and also vary very widely from person to person. But there are some consistent patterns at a sort of population level. So we know that the maturation of the cortex continues to mature with age, and this is depicted by the kind of dark blue to kind of purple colours that progresses, from age 12 to age 20, and this is generally shown to be last to mature in the prefrontal cortex. These are some plots that Professor Cherbuin just already kind of showed in the previous talk. So these are the brain charts plots by Bethlehem and colleagues. And here again, we do see that there are substantial changes in grey matter volume and subcortical volume with age, and these also occur before the age of 18 years. And these brain changes are also verified by a number of longitudinal studies. And this again is over this developmental period from early childhood to early adulthood, that again just verify that there are these substantial reductions in grey matter volume with age, particularly in that adolescent period. So are mental health disorders possibly linked to brain development? And I guess because there's a lot of temporal correspondence between the age of onset of many mental health illnesses and also this continual refinement of brain development, this has largely placed the brain at the centre of much of mental health research in the past. So although there is a number of, there is heterogeneity across studies, a number of longitudinal studies have revealed both attenuated and also accelerated patterns of grey matter development in youth with various symptoms or diagnoses of psychiatric conditions. So, for example, Whittle and colleagues reported reduced or attenuated cortical thinning in children who had increases in internalizing symptoms over time from early or late childhood, whereas another study by Boss and colleagues showed increased or presumably accelerated cortical thinning in the frontal lobe in adolescents with emerging depressive symptoms at the follow-up period, as depicted by this deeper red line in the figure to the right. So just to note, I guess, collectively about some of the previous studies, many of these studies have focused on select brain regions, such as focusing only on the prefrontal cortex or the hippocampus, or particular brain matrices, such as cortical thickness, or they may have just focused on select mental health symptoms, such as anxiety or only depression, rather than a range of conditions. But collectively, we thought that at the time of this work, that the previous research suggested that there might be a deviation from normative patterns of brain development might be important in the emergence of psychopathology, and that this deviation could also cut across psychiatric boundaries. So this, in some ways, lent us to think about how it is best, how should we best measure brain development or deviation in brain development or aging. And so one method that has become increasingly popular over the last sort of several years is to characterize this with brain age prediction models. And I'm sure there's many people in the audience that have used these models in their own work, but basically it does involve a type of machine learning model to imaging data, to learn patterns from the data, and then to use these patterns to make predictions about new data. So in this way, you know, the brain imaging features, along with a person's actual chronological age may be fed into a machine learning model to best predict the person's age. And these patterns would then be applied to an unseen data set without the age labels to test how well the patterns predict the age of the unseen subjects. So the main outcome measure in these brain age prediction studies is the brain age gap, which is defined by subtracting chronological age from the brain predicted age. And with the brain age gap, here, what's most important is that a person with a positive brain age score has a brain that might appear older than the person's chronological age, whereas a negative brain age score denotes or implies that the person has a brain that appears younger than their chronological age, whereas a brain age gap score of 0 would imply that the person's brain and actual age are the same. So this particular approach has become, as I said, increasingly popular, particularly in the last 5 or so years, and has been applied also in psychiatric disorders. So for example, a quite elegant and large transdiagnostic study by Kaufman and colleagues examines the brain age gap as shown by these rain clouds across a number of neurological and psychiatric disorders. And they found advanced brain age gap indexed by a positive brain age gap score relative to the control group in the grey, and which was common across many, but not all, neurological and psychiatric disorders. And that included dementia, MCI, multiple sclerosis and schizophrenia, but also included bipolar disorder and mixed psychotic disorder as well. And here is another study that used data from the Enigma Consortium that also found a higher brain age gap of only just approximately 1 year in patients with major depressive disorder compared with controls. Although, you know, it is to be noted that there is substantial overlap between group overlap in the brain age gap values as well. So the higher brain age gap scores in these previous studies do imply that the brain appears older than its chronological age across many psychiatric disorders. So in other words, this might mean that someone with a true age of 45 years may have a brain that appears to be 50 years of age. And individuals that have different conditions, such as schizophrenia or depression, are more likely to have these older brains. But in terms of these other studies, in general, most of the studies have applied these brain age models in adult populations, perhaps in middle age populations, and also in cohorts with established diagnoses of a psychiatric condition that likely have had this particular diagnosis for many years. So this raised a couple of questions for us. So firstly, it raised the questions as to when do the deviations in brain development or brain aging might first start to emerge. So is it more likely that they start to emerge with age, or do we actually start to see these deviations from chronological age at younger stages of development, when we know when the mental health symptoms first start to manifest? And secondly, do the deviations in brain development or deviations from chronological age only occur when in individuals who have these overt, fully threshold psychiatric symptoms that actually warrant a psychiatric diagnosis? Or do we actually see some of these deviations in individuals with less severe forms of the mental health symptoms? So this might be in line with the continuum model of mental illness, whereby symptoms of mental health might be proposed to follow a continuous distribution and also share common neural correlates that also might likewise follow this continuous distribution. So with that in mind, this was sort of the aims of this particular study that I'm just going to be focusing on today. And so in this study, we used the brain age paradigm and also a dimensional approach to probing psychopathology to examine this relationship. And so our aims were to identify the associations between the brain age gap and multiple dimensions of psychopathology in youth. And secondly, we aim to determine whether the brain loci with the most prominent deviations between chronological and brain predicted age are shared between the psychopathology dimensions as well. So we carried out this research using data from the Philadelphia neurodevelopmental cohort. And so this is a publicly available, or at least to researchers, a data set based or stemming from the USA. And so the cohort consists of nearly 10,000 individuals or youth aged 8 to 21 years who underwent a psychopathology demographic and also cognitive assessment. And a subsample of the individuals underwent neuroimaging as well with these various acquisitions. But for the current study, we were primarily interested in the T1 scan as well as the psychopathology interview. And from this data, we had a final sample size of just over 1,300 youth after we applied various exclusions and quality control to the data. And using particular criteria, we defined about 400 individuals as typically developing. And the individuals who did not meet our criteria as being typically developing based on various constraints were classified in the non-typically developing group. So to actually analyse or identify dimensions of psychopathology, we used independent component analysis, and we followed a previous method by Alnius et al. In the data set to do this. And so it was actually done on the larger PNC data set, so that consisted of about 9,000 individuals. And using this method, we identified 7 dimensions of psychopathology that range from an absence of any symptoms to having sub-threshold or attenuated symptoms to potentially having more clinically threshold symptoms. And we found these were represented by what we called conduct, anxiety, obsessive compulsive, attention, depression, bipolar, and psychosis. And we also computed a general psychopathology dimension that was just the average of the 7 dimensions here. So in terms of our brain age prediction model, we did this in the following steps. So we use support vector regression with tenfold cross-validation to train the model on the typically developing youth to predict the individual age. And we did this based on 111 structural imaging features extracted from FreeSurfer. So that included cortical thickness, volume, surface area, ventricles, and ICV. And the model trained on all of the typically developing youth was subsequently applied to the non-typically developing sample to predict the age of each of these individuals. And then the brain age gap was computed by subtracting chronological age from the brain predicted age, and following recommendations to correct for the regression to the mean bias, we regressed age from the brain age gap scores, and the resulting residuals were used in the subsequent analyses. And in these analyses, we were primarily interested in associating or using a GLM to examine whether variation in the 8 psychopathology dimensions were associated with variation in the brain age gap. So I won't labor on the demographics, but here in terms of demographics, the individuals were about 14 years of age, evenly distributed in sex, average IQ, and these didn't markedly vary over the different psychopathology dimensions when we did a weighted mean for that. So in terms of how well our model performed in terms of predicting age, so we found that in the typically developing individuals, the brain imaging or features predicted age with a mean absolute error of about nearly 1.5 years and a correlation between chronological and predicted age of 0.82. And in the non-typically developing individuals, the mean absolute error was 1.6 years and the correlation coefficient was 0.72. So the schematic below here just shows I guess the regions, the relative importance of each of the features to the predicting age, and it's visualized by beta weights of the predicted age for each of the features. And this shows that, you know, the warmer colors represent or correspond to a positive association, and the cooler colors correspond to a negative association with predicted age. So this shows that some regions or metrics have a negative correlation with predicted age, such as cortical thickness, but also some, such as surface area, particularly in the parietal cortex, have a positive correlation with predicted brain age. So that's something that we would typically expect. So I'll just briefly touch on that given that white matter microstructure also undergoes substantial changes over this period of development, we were interested in seeing in a secondary analysis whether the inclusion of white matter actually improved the brain age prediction model. And so we did this by just including the different diffusion metrics as extracted by the Johns Hopkins University Parcellation Atlas into the brain age model, along with our original grey matter or structural features. And the inclusion of the white matter microstructure features actually reduced the prediction accuracy. So this resulted in a mean absolute error of 1.93 years and a Pearson's correlation of 0.75. And so due to this kind of poorer brain age estimation, with the addition of the white matter features, our brain age model just included the grey matter structural indices for the other analyses. So just to touch on our main aim in terms of associating the brain age gap with psychopathology. So we did find that individual variation in the brain age gap was associated with variation in obsessive compulsive symptoms, psychosis symptoms, and general psychopathology. Of course, it is of a small magnitude. For all the associations, the direction was positive, so this implied that a higher brain age gap was associated with greater symptom severity. And these associations remain significant after considering potential confounders such as psychotropic medication, such as IQ, Euler number, as well as traumatic stress exposure. And then also when we looked at the individual clinical items from the clinical interview, 37 of these items were significantly related to the brain age gap. And the majority of these did relate to the psychosis and OCS dimensions. So here's just to give a little bit of an illustration or flavour to the top individual items that were related to brain age gap. And as you can see, they touch on having strange feelings in your body, being bothered by thoughts that don't make sense to you and that are quite repetitive, hearing own thoughts being said out loud or not making sense, or possibly having the experience of someone interrupting or controlling thoughts. So they clearly do sort of align with the psychosis and OCS dimension. So we also examined brain age gap using a categorical approach, just as a secondary analysis. So here, individuals with a lifetime endorsement of any of the items within the GOASIS clinical screen that pertain to the psychosis or obsessive compulsive screening categories were grouped into the psychosis and OCS group respectively. And we found that the brain age gap was significantly higher in the psychosis group as well as the obsessive compulsive group compared to the typically developing individuals. And we also found a significant interaction between age and group for both of these categories. And in this interaction, this indicated that the brain age gap score was actually highest for the younger individuals. So those individuals who are about 8 to 10 years for both the psychosis and the OCS groups. So although we found that brain age gap score was associated with higher symptom severity overall, we found that this was particularly driven by the younger individuals. So we next wanted to identify what brain regions might actually be most important to these associations with psychopathology. So we did this with what is called an inclusion or omission sort of analysis. So I'll just briefly go through this because I know what the time is. So here we just essentially retrained our brain age model like before, but omitting particular lobes or features. So here we did the SVR with all features except for the frontal lobe, except for the temporal lobe or parietal lobe, and so on, and calculated the brain age gap like before, and then also computed the association with the psychopathology dimensions. And what we were interested in seeing is if there was a reduction in the effect size or the T-stat value that pertained to that association, this indicated that that particular feature was important for the association. And so here are the results of this association between brain age gap and psychopathology with this omission. So here in this panel A, this basically shows the features that reduce the association with brain age gap across each of the dimensions, with the larger text implying the greater reduction. And panel B shows the reduction in the various variants explained with the feature omission. So we found that the association between positive brain age gap and psychosis was weakened with the omission of the frontal lobe, whereas the association between brain age gap and OCS and general psychopathology was weakened with the omission of subcortex and insula. And just lastly, we wanted to know whether the clustering of the psychopathology dimensions occurred based on these most important features or brain loci. And so this was done with the Ward's cluster analysis. So here, this is just a correlation matrix and a network representation of the associations across the dimensions relating to these important loci. And we found 2 clusters of common brain loci. One cluster comprised the conduct, depression, psychosis dimensions, and the other comprised OCS in general and the other dimensions. And just one more minute to just summarize this research. So here we revealed that brain age gap increased with increasing severity of symptoms along the dimensions of psychosis and OCS, as well as general psychopathology, suggesting putative accelerated aging. We found that the younger individuals had the higher brain age gap score. Perhaps they're more vulnerable to altered brain development. And we found that these psychopathology dimensions clustered into 2 distinct modules. And just in terms of considerations, the brain age gap scores were relatively weak, although comparable to other studies. We don't know what might be actually really underlying that brain age gap. And again, it was a cross-sectional design. And with that, I'll just end with acknowledging other co-authors. Thank you.
Hey, wonderful. Thank you so much, Vanessa. And I'll just say we'll do some questions at the end for everyone. But if you do have any questions for our panelists today, please put them in the chat or in the Q&A, and we'll have time for 1 or 2 questions at the end. So now, next up, we have Claire Kelly, PhD candidate and RA at the Turner Institute for Brain and Mental Health at Monash University and the Victorian Infant Brain Studies Vibes and Developmental Imaging Group at Murdoch's Children's Research Institute. So Claire's research is dedicated to unraveling the impact of early life experiences, particularly preterm birth, on brain development and neurodevelopmental outcomes. So through advanced MRI analysis techniques, Claire seeks to deepen our understanding of how these experiences shape the developing brain. So Claire, the floor is yours.
Great, thank you. Just share my screen. All right, so hopefully everyone.
That's great. Yeah.
Great, thank you. So hi everyone. It's great to get to talk to you about some of our recent work where we're looking at the brain age framework to help us understand brain maturation in children, and my work is particularly focused on children who were born preterm. So we'll get into it. We know brain development involves a really precisely orchestrated sequence of genetic, biochemical, and physical events that form and organize and reshape the brain. And these events take place right from the earliest stages of fetal life through to adulthood. But they're particularly rapid and dynamic in the first 2 years of life, when we see really large increases in subcortical volumes and cortical volume, area, and thickness. And of course, brain development plays a really important role in the cognitive, affective, and behavioural development that we know is occurring alongside brain development. A lot of work has shown also that experiences early in life have a profound influence on brain development and lifelong functioning. And there has been a lot of research, and there is a lot of research occurring looking at the effects of early experiences of stress and adversity on the brain developmental trajectory. And several different theories have been put forth to explain how early stress and adversity might affect brain development, and there have been different findings. I just wanted to highlight some recent studies that suggest that early life stress could be related to an accelerated brain maturation and aging trajectory later in life. But like I've mentioned, my talk is going to focus on very preterm birth. And so we know infants who are born very preterm are exposed to a lot of stressful experiences in the months to weeks following birth, during times that they have to stay in the newborn intensive care unit and undergo important life-saving medical procedures. So from a research perspective, we can see very preterm birth as sort of a summary of different stressful early life experiences. And because of this difficult start to life, we know that children born very preterm are more likely to suffer cognitive, motor, and behavioural difficulties throughout their lives. And we are concerned about the aging process later in life in those who are born very preterm. So there is some recent research suggesting that those who are born very preterm could be at risk of earlier onset of chronic age-related diseases later in life. Across different bodily systems, we see that adults born preterm have reduced airflow capacity and poorer cardiovascular health and advanced epigenetic age. In terms of the brain, studies have found that adults born very preterm exhibit structural deficits, including reduced volumes in subcortical regions like the hippocampus and temporal cortical regions, which we know are sites of atrophy in neurodegenerative diseases. And there have been 2 recent studies that have found a significantly increased brain age gap in young adults born very preterm compared to those born at term. So the prior talk by Vanessa gave a really great description of the brain age framework. So I'll just talk about this briefly. In the brain age framework, we integrate brain MRI data into a multivariate model to predict age using machine learning techniques. And then we can look at the difference between the predicted age from MRI scans and the true chronological age of individuals. And that difference, the brain age gap, gives us a measure that can index the degree to which individuals deviate from a typical brain aging or brain developmental trajectory, depending on which population is being studied. And so there has obviously been a lot of work that has applied the brain age framework to older adult populations and has found that a higher brain age delta has been associated with different health concerns and neurodegenerative and neuropsychiatric diseases. But the brain age framework is also more and more often being applied to developmental populations to look at accelerated and decelerated brain maturation in various developmental populations. We recently performed a study which was led by Gareth Ball at the Murdoch Children's, where we used the brain age framework and model explanation methods to study brain development in a typically developing sample. And in this study, we found that brain age prediction and the cortical features that explain predictions were consistent across different brain age model types. And we looked at linear, nonlinear, and ensemble models and reflected previously reported patterns of brain development. There was significant between subject variation in the features that explain brain age predictions, but there was no association between brain age and cognitive performance in this typically developing sample. But there still have not been many studies that have looked at the brain age framework in cohorts born very preterm. So there is still a lot that remains to be known about the effects of very preterm birth and other early experiences on brain maturation and brain aging. So in this work, I aim to investigate the influence of very preterm birth on brain maturation in later childhood and adolescence based on the brain age framework. And so I was looking at whether accelerated or decelerated brain maturation could be detected in this time point of later childhood and adolescence. I also aim to look at which specific brain regions and measures contributed to brain age predictions in those born very preterm using a novel model explanation method, which I'll describe in more detail. Thirdly, I aim to look at which specific perinatal risk factors are associated with brain age in those born preterm. And finally, I aim to determine whether brain age is related to long-term neurodevelopmental outcomes in those born very preterm, including cognitive and motor outcomes. So to train a brain age model, we needed a large typically developing data set. And so the data set that we used here is the Pediatric Imaging, Neurocognition and Genetics data set, or the PING data set, and that's comprised of 768 typically developing children aged between 3 and 21 years of age. And the data set that we applied the brain age model to is our Victorian Infant Brain Studies cohort, or VIBES cohort. So this is a unique longitudinal MRI study. We recruited the babies around the time they were born. We recruited both a group of very preterm babies and who were born less than 30 weeks of gestation, which is about 2 months early, and a group of full-term babies as well, which we define as greater than or equal to 37 weeks of gestation. And these infants they returned for MRI assessments at 3 time points, so around the time they were born and age 7 and age 13 years. And they also returned for neurodevelopmental assessments at several time points, including age 13 years. So we had data for about 130 very preterm participants and 30 full-term participants. And in this study, I've used T1 weighted images for both cohorts. But both cohorts did have other sequences collected as well. So for the PING cohort, the T1 images were acquired on 3T scanners at 7 sites across the US. And for the VIBES cohort, the T1 images were acquired on a 3T scanner here at the Royal Children's Hospital in Melbourne. And I processed the T1 weighted images using the standard FreeSurfer pipeline version 6 and extracted volumes and subcortical volumes and cortical volume area and thickness from regions, which I'll show you in the next slide. I also performed harmonization of the data extracted from FreeSurfer using the COMBAT tool while preserving biological variability associated with age, sex, and group. So this table is showing the features that are extracted from FreeSurfer to use in the brain age modeling. So this is the volume, area, and thickness of cortical regions from the Desic and Kiliani atlas, and the volume of subcortical structures shown here. I then constructed a Gaussian process regression model to predict age based on these MRI features. And so the reason we selected a GPR model was because this is a nonlinear model which has been shown to have high performance in predicting age. And in our prior study where we compared several different brain age modeling types, we found that the GPR model was the highest performing model. After constructing the model, I validated the model using a tenfold cross-validation procedure stratified by site, which was performed just on the training ping dataset. And I performed permutation testing as well to test the significance of model fit. So then I applied the trained model to predict age in the test dataset, the VIBES dataset. And for every participant in the VIBES dataset, I calculated the brain age gap, which was the predicted age minus the chronological age. So a higher brain age gap or positive brain age gap indicates that the predicted age was older than chronological age and vice versa. And I compared the brain age gap between preterm and full-term groups and correlated it with clinical variables in the preterm group using linear regressions, all adjusted for age, sex, and intracranial volume. And finally, I looked at which features were contributing to the age predictions using a novel model explanation method known as SHAP or Shapley additive explanations. So this figure is showing the performance of the brain age model in our training data set. So this is just showing that we were able to generate a good performing model with a high correlation between chronological age and predicted age for every, which is shown here for every participant in the ping data set, and mean absolute error of 1.72 years, which is in line with other studies in the field, including other studies based on this cohort. I then applied the model to our VIBES cohort, and here I'm showing the brain age gap for every participant at age 7 and 13 years. So we can see the preterm group here in orange and the full-term group in blue, and I found on average that the brain age gap was higher in the very preterm group than the full-term group, but this difference didn't reach statistical significance at either time point. I also found a few other things to note is that variation in the brain age was higher in the very preterm group than the full-term group. And also brain age was overestimated for all participants at age 7, which we think reflects a regression to the mean effect, where age is overestimated for younger participants and underestimated for older participants, which is why we corrected for age in our analyses. So even though we know from prior research that children born very preterm exhibit brain structural deficits at cross-sectional time points, we think this finding reflects that brain maturation between this period of age 7 and 13 years is relatively similar between groups. Several prior studies have suggested the presence of delayed brain development at earlier time points in preterm children, but this is suggesting at this time point, we're not seeing strong evidence of delayed brain development. If anything, we're seeing a trend towards accelerated brain maturation, which is in line with studies in older young adults born preterm. I also looked at the change over time in brain age delta, and which I found that the group differences in brain age delta were stable over time between the preterm and full-term groups. And this plot is showing the relationships between brain age gap and different clinical factors. I looked at perinatal factors that we collected around the time of birth, including gestational age, birth weight, whether the child was born small for gestational age, sex, brain injury and abnormality, which was diagnosed by clinicians on early MRI and ultrasound, and lung injury. And I also looked at outcomes collected at 13 years, including IQ, memory, language, and motor function. But I didn't find strong evidence for relationships between these factors and brain age in the preterm children. And other studies in this field have found that correlations between brain age and cognitive performance are generally small to moderate only in pediatric populations. So I think there's a lot more research that needs to be done on the relationship between brain age and cognitive performance in pediatric populations. And finally, this is showing the features that contributed to the model explanations in the very preterm group. I found that the important features included the thickness of temporal and primary motor regions, volume and area of parietal, frontal and temporal regions, and volume of the brainstem, cerebellum and ventricles. And the feature contributions were similar in the preterm group and the full-term group. So in the next slide, I'll show the full-term group as well. So we can see similar feature contributions. So we think that these features reflect typical patterns of brain development. So to summarise, we were able to establish an accurate model of brain age based on structural MRI data in children. And using this model, we provided unique insights on brain maturation following early life experiences surrounding very preterm birth. And our findings are forming part of a growing conceptual shift that we're seeing in this field towards considering the span of brain development and aging following very preterm birth. Some important points that I also wanted to note is that caution should be applied when interpreting brain age delta, because we know brain age modelling collapses the impact of many factors into a single measure, and work has shown that factors other than aging or development can affect brain age modelling, such as image acquisition and modelling parameters. Future work with additional longitudinal follow-up into the later adult use will be really important to really detail the effects of very preterm birth and other early life experiences on brain development and aging. And future work, like I mentioned, looking at the relationship between brain age and developmental outcomes will be important. This work is focused on structural MRI, but additional work incorporating other modalities would be useful to really fully characterise the effects of very preterm birth on brain maturation, along with future work using model explanation methods to potentially to stratify high-risk subgroups, because we see that there is a lot more variation in brain age scores in the preterm group, which could indicate the presence of distinctive subgroups. And I just wanted to finish by acknowledging everyone who has contributed and supported this work. The publication and code are available online and can be accessed through those links. And thank you for listening to my presentation.
Thank you very much, Claire, for sharing your insightful research findings with us. Now I'd like to open the floor for a brief question and answer session. If anyone has questions, feel free to post in the chat, and we have a few minutes to delve deeper into these fascinating topics. In the meanwhile, I had a question to start the Q&A session. It's particularly from Nick, but everyone feel free to give us your insights. I was wondering if there's a way that we could get from brain aging research into influential research towards future practices of diagnosis or treatment of mental illnesses, and whether, like, what is the path from where we are looking at brain aging and how it impacts all these different mental disorders such as dementia, to somewhere that we could actually implement this into interventions.
Good to start with an easy question. So I think, I mean, we can take a question like this from very many different points, but I think we have to be able to link the underlying hypothesized mechanisms with the change in brain, whether it be structure, metabolism, or things like this. Because one limitation of the current research, our research, and everyone research is that we assume too much that it's linked in a certain way to the exposure or the mental illness we're interested in. And while it's reasonable, we still have to demonstrate that an alternative is not a better explanation. And this is tricky, and without having mechanisms underlying the pathology and testing the effect of the mechanism on brain structure and function, but also testing moderating factors to see whether, or mediating factors to see whether, if you intervene, it makes a difference. So I think the interventions have to be designed so that you can test mediation or moderation between the exposure and the outcome in the brain. If that makes sense, that would be one possible way of doing it.
Thanks, Nick. We've got a quick question here from the chat for Claire, which is why were all SHAP values positive?
Yeah, we looked at the absolute SHAP values. So it was essentially, yeah, a higher absolute SHAP value just indicated that the feature contributed more to driving the predictions away from the mean of the full-term group. So not really sure if that answers the question. We have more details in the publication, maybe.
Yeah, I'm sure they'll follow up on that question if they do. I just have one question for everyone, I think, it kind of relates. So for those of us who are sort of in the clinical and neuropsychiatric sort of MRI field, and we're using age as a covariate, it seems like it's a lot more complicated than initially thought. You can't just enter that into your model and say, hey, there's brain aging taken care of. Should we be using something a little bit more complicated or a little bit more sophisticated, I guess is the word, such as tools like this brain age framework, instead of just, you know, partitioning out for age? What do you all think? Maybe Claire, you've got some insight there.
So sorry, could you repeat the question?
Yeah, I'm just sort of thinking with some of us add age as a covariate into our analyses, but it seems like it's a lot more complicated. There's a lot more going on than just accounting for age as a sort of linear variable. Should we perhaps be a bit more using more complicated tools or more sophisticated tools like that brain age framework or something similar? Right.
Yeah, it's a good point. I mean, in our brain age modeling, we have just included age as a linear regressor. Of course, I guess this needs to be done in combination with other analyses. Maybe in some subsequent work, we're performing some nonlinear modeling, looking at the relationship between age and the development of these cortical metrics. I'm not sure if the other panelists have more thoughts, but yeah, it's a good point.
I think it might depend on the research question. I guess in some of your studies, you might be trying to just kind of hold the age constant and adjust for age, whilst here, I guess we're specifically interested in the effects of modeling age. So that would be, you know, one point. And with some of these models, such as even normative modeling as well, you know, I guess the advantage is that you might be able to supposedly get at that individual level differences rather than kind of like the group level for that you know, group mean, that they're able to kind of like identify the for each individual their particular deviation in brain development or brain aging from their chronological age. So I guess that's maybe some of the advantages to those approaches, but of course, you know, it's a bit of a black box, and there's many disadvantages as well. And there's many, of course, over the last couple of years, critiques, I think, in terms of some of the brain age models, in terms of understanding what the measurements are actually indexing, you know, and there could be many different kind of things that might be going into the measurements that come from these particular models. I don't know whether Professor Cherbuin might have some other points to mention as well.
Just Nick will be enough. I think that it would be interesting to have nonlinear corrections, but I mean, the mind boggles when you start thinking about this in the context of brain age. So I'm not sure how feasible and interpretable it would be. But having said that, you know, it's something to be tested. I think one perhaps a better way of addressing this, and it's partly a comment, but also a question for Vanessa, is the use adapting brain age in a way that it can be applied longitudinally. One problem with cross-sectional estimation of brain age, and we've used brain age as well, and I'm as guilty as anyone else, is that we assume that it's not something that wasn't already there in those people who are older. And if you've got very large samples, it's probably reasonable, but there is always this question is, you know, for some unknown reason, are the older kids different for some other reason? And unless we able to model longitudinally brain age, and I know it's very difficult because it's not a type of metric at the moment that we can normalize across time in the same individuals. But I think this is what we have to aspire to, either in the current brain age framework, or maybe it requires using something like diffusion that is a physically more stable metric across time. I'm not sure. It's not my expertise really, but this is, you know, this is the gut thing I have, that we need to get to some of these things. What do you think, Vanessa?
Yeah, I think you raised some really good points, Nick. I mean, yeah, obviously with these cross-sectional data sets, which are age-diverse cross-sectional data sets, you can't rule out, you know, what you just raised. And I think it just illustrates the need for, yeah, some other longitudinal work in this area. And I think there are some, you know, a few studies that have looked at, you know, longitudinally the brain age sort of delta. But I don't know the exact premise of that work, but I think that needs to be done in that direction to try to understand what might be actually driving some of these estimates, and whether, I guess, there is actually accelerated aging. You need more than just, you know, 2 time points to actually really infer that as well, like whether it actually is increasing over time, or whether it's stable and so forth. But I mean, I think I just agree with your points. I don't know whether I'd have much to add in that kind of regards. I don't know.
Well, in the interest of time, I think we've only got a few very dedicated people left in the webinar, but I've really enjoyed it myself personally. So I would just like to thank our panelists, of course, Vanessa, Nick, and Claire for joining and for giving us such insightful speeches and on this great topic. Yeah, I'd just like to thank everyone and draw this to a close. So thank you so much. Wonderful.